Thank you very much, LIGHTMED, for allowing me to talk about one of my passions, which is lasers for glaucoma therapy. Today, we'll focus on selective laser trabeculoplasty, leading it with success. I am a glaucoma and advanced anterior segment surgeon in the Atlantic Canada, New Brunswick province of Canada out east, and I have two affiliations with two universities. So these are my financial disclosures. So what our agenda for today would be history of laser trabeculoplasty. We'll discuss SLT as first-line treatment. We'll talk about pearls on SLT, but also a little bit about subthreshold laser trabeculoplasty. And we'll end with benefits of laser trabeculoplasty, some literature comparing SLT and subthreshold, benefits over drops, and a few case presentations. So history. So argon laser therapy or argon laser trabeculoplasty started way back in the 1970s. This first study was published in Archives of Ophthalmology in '79. And this basically studied argon laser applied to 360 degrees of the trabecular meshwork. The study included 56 eyes, and they did the typical parameters used for argon laser trabeculoplasty, which is about 100 spots, 1,000 to 1,500 milliwatts, 0.1 seconds, and the spot size was 50 microns. And we'll see how that differs from what we do currently. What the study found was 41 eyes were controlled with argon laser trabeculoplasty, 27 eyes required medical therapy, 6 eyes, which is 10%, actually required surgical therapy, and the mean IOP lowering was 10 millimeters of mercury up to 18 months, which is pretty significant. It showed no angle scarring, no serious complication, and presumed mechanism of ALT at the time was increase in trabecular meshwork tension. And the conclusion was that ALT appeared to be an effective alternative to filtration surgery in phakic eyes. Argon laser trabeculoplasty was first described even earlier in '74. Thereafter, we saw the study in '79. And in the 1990s, the National Eye Institute funded a randomized control trial, the Glaucoma laser trial, which randomized patients to receiving timolol versus 360 degrees of ALT. And they basically concluded that laser trabeculoplasty was efficacious as medical therapy for treating primary open-angle glaucoma. And we're actually going to delve a little bit into the glaucoma laser trial. So as we said, the glaucoma laser trial, GLT, is a multi-center randomized controlled clinical trials of 271 eyes, which looked at the safety and efficacy of argon laser trabeculoplasty compared to timolol 0.5%. This was for newly diagnosed bilateral open-angle glaucoma patients. One eye was assigned to topical therapy. The fellow eye was assigned to initial ALT. And the study evaluated immediate effect of ALT and long-term effect. They looked at need of medication, visual field deterioration, optic nerve deterioration, visual acuity, and adverse reactions. The glaucoma laser trial had several publications, and I will discuss the second publication, which was the results of argon laser trabeculoplasty. And each patient had one eye randomized, randomly assigned to either ALT, and they call it the LF or laser first eye. The other eye was assigned to timolol or medication first. Throughout the 2-year follow-up, what they noticed was that the laser first eye had a lower mean IOP than the medication by about 1 millimeter or 2. Fewer laser eyes than medication required simultaneous prescription of 2 or more medication. After 2 years, they also noted that 44% of the laser eyes were controlled by ALT alone. 70% required ALT plus timolol, and 89 were controlled within this stepwise medication regimen. After the 2 years in the medication arm, 30% of the medication eyes remained controlled. So we have 44 over 30. 66 were controlled within the stepwise regimen. They concluded that there were no major differences between the two treatment approaches with respect to change in visual acuity or visual field over the 2-year follow-up. The GLT study 7 showed that over the course of the glaucoma laser trial follow-up study, eyes that were treated initially with ALT had lower IOP, better visual field, and optic disc status than their fellow eyes treated initially with topical medication. As compared to eyes initially treated with medication, eyes initially treated with laser had about 1.2 millimeter greater reduction in IOP, which was statistically significant, and 0.6 decibels greater improvement in their visual field, which was also statistically significant. The overall difference between the eyes with regard to change in the ratio of cup to disc ratio and the optic disc was also significant, which indicated a slightly more deterioration for the eyes treated with medication. In conclusion, initial treatment with ALT was at least as efficacious as initial treatment with topical medication. So now we're moving to SLT, selective laser trabeculoplasty, which was introduced about 5 years after the study by Latina and Park. SLT utilizes a 532 nanometer Q-switched double frequency YAG laser. It prevents the heat dissipation in the trabecular meshwork, reducing collateral damage, was approved by FDA in 2001. And SLT is thought to reduce IOP by increasing aqueous outflow through the trabecular meshwork. I'll present now a study that was actually done here in Canada, comparing SLT as primary therapy versus prostaglandin analogs. It randomized 100 eyes into 74 which received SLT, 26 received a prostaglandin analog. And the conclusion of the study, as we can see by this table, is that SLT was found to be equally efficacious as latanoprost in reducing IOP in newly diagnosed open angle and ocular hypertension over a 12-month period. Non-steroidal anti-inflammatory had similar efficacy to steroid after laser therapy, and that is something we will touch upon later on. And basically, the study supports the consideration of SLT as the first-line treatment for newly diagnosed patients. So now we'll move to SLT as first line for ocular hypertension and glaucoma. So when we talk about selective laser trabeculoplasty, a most recent study published in The Lancet spoke about or studied selective laser trabeculoplasty, SLT, versus eye drops for first-line treatment of ocular hypertension and glaucoma, also called the LIGHT trial. And that was a multi-center randomized control trial. Our current space of glaucoma and glaucoma intervention is currently changing. Our glaucoma paradigm is changing. The paradigm is actually shifting into earlier intervention. And Ike Ahmed, also known as the Canadian Glaucoma and Advanced Anterior Segment, and used to be my fellowship mentor, he coined the term interventional glaucoma, whereby we look at interventions such as SLT and minimally invasive procedures to reduce medication burden and solving the compromised compliance issue with patients. Now to the LIGHT trial. The LIGHT study, designed to question a change in clinical pattern for the use of SLT first versus drops for the treatment of ocular hypertension and primary open-angle glaucoma, It was a prospective randomized control multi-center study, which included 6 glaucoma clinics in the United Kingdom, ranging between 2012 and 2014. The study hypothesis was would SLT as primary treatment for lowering IOP provide a better health-related quality of life, lower cost of care, and improved treatment tolerability with less need for medication. Inclusion criteria included newly diagnosed open-angle glaucoma and ocular hypertension, treatment-naive patients, patients above age 18, and patients that were capable of reading and understanding English. Some of the exclusion criteria were secondary glaucomas and other eye diseases. Primary outcome measured looked at health-related quality of life at 36 months. Secondary outcomes were glaucoma treatment related to quality of life and clinical effectiveness, percent of visits at target, number of escalation therapy, and healthcare resource use. In this table, we can basically see that SLT provides superior IOP stability to drops at a lower cost. 74% of patients successfully were controlled without drops at 3 years. Both groups had similar endpoints such as IOP, visual acuity, and visual field loss. The secondary outcomes suggested better health-related quality of life outcomes for the SLT group. There were more ophthalmic drop-related adverse events reported by the patients in the eye drop group. There were 150 aesthetic side effects or ocular allergic reactions reported, and compared to SLT, which were significantly less. So when we think of SLT first, we see that we get better IOP control, however, more visits at target over 3 years, less therapeutic escalations, less disease progression with SLT, less intense drop therapy, no glaucoma surgery, and less cataract formation. Thus, this is the first study that reports disease control without topical medication provided by primary SLT, and does so with realistic but stringent targets for IOP and objective escalation criteria. No systemic adverse events were noted from SLT. One SLT resulted in an IOP spike, which 1 out of 776 procedures is very minute. SLT as a first line, overall cheaper than drops. And for every SLT given first instead of an eye drop, the cost savings are greater than the cost of SLT for 2 additional patients, or equal to the cost of 5 additional ophthalmology specialist appointments. So the study design made results applicable to daily life, target pressure, consider disease progression and treatment escalation, strict decision-making protocol, and fixed follow-up appointments. In conclusion, primary SLT is a cost-effective alternative to drops that can be offered to patients with open-angle glaucoma or ocular hypertension needing treatment to lower intraocular pressure. Interpretation of the study is that selective laser trabeculoplasty should be offered as a first-line treatment for open-angle glaucoma and ocular hypertension, supporting a change in clinical practice. So now we'll move, I'm kind of jumping a little bit to the benefits of laser trabeculoplasty. So I'll just touch upon basically our machine that is a LIGHTMED machine. It's a tri-laser light mass YAG SLT, and it does have an argon component, which is the 532 subthreshold laser. So what we can see in the center is our YAG SLT module, and we have our argon laser attached to it. we have exactly this same machine, has an elbow rest, so ergonomics is really critical. It rests on a beautiful cart. We actually have it in our pediatric lane, which is a 20-foot lane, and we basically move it 90 degrees from its resting position to its active position. And something that really helps, basically almost no wires, even the foot switch is wireless. That's actually myself being treated probably as a second patient on this machine. I had a barrier laser for my myopic retinas. So that's me, and that's live, and that's real. So a little bit of literature comparing SLT with micropulse or subthreshold laser trabeculoplasty for the treatment of open-angle glaucoma and ocular hypertension. This study was a controlled, prospective, longitudinal clinical trial which objectively compared the efficacy of subthreshold or micropulse laser trabeculoplasty with SLT, done on 67 eyes, which were included in the trial. 38 had SLT of the 24, and 29 eyes had the subthreshold laser. The application of the laser was carried out by glaucoma fellows under the following parameters. So group 1 received SLT with a LIGHTMED device over half of the trabecular meshwork. And the other group received the subthreshold laser trabeculoplasty, but the laser was performed over 360 degrees. So group 1, half of the TM, group 2, the entire 360. What we can see as the mean baseline and post-laser procedure is that there was a significant decrease in IOP in both groups. And when we look at IOP reduction, we can see that there was a significant reduction in 30, 20, and even 15% reduction in IOP in both groups. We always have a minute amount that are non-responders. So when we look at our ideal patient, so say you are to do your first laser clinic and you're thinking, who am I going to recruit as my first ideal patient for laser trabeculoplasty? So the ideal patient would be a middle-aged person, middle-aged woman or man. Typically, you want to have a nicely open Schaefer grade 3 or 4 angle, mild pigment in trabecular meshwork, because that will help guide you exactly where to place the beam. Although when we talk about selective laser trabeculoplasty, the beam is about 400 micron, which encompasses the entire trabecular meshwork. When we do the micropulse or the subthreshold laser trabeculoplasty, we use a 300 micron target or beam, have the patient have either ocular hypertension or mild open-angle glaucoma. And definitely, as we've seen, this can be the first line of therapy for the patient. And as I said, likely best to start with patients with either ocular hypertension or mild visual field loss. And also, if a patient is not keen on daily drop regimen, of course, laser trabeculoplasty, SLT, would be a great option. Some pearls about SLT and subthreshold laser. So what I do prior to my laser procedure, be it an SLT or a subthreshold laser, naturally we all have to consent our patients to the procedures, discuss the risks, benefits, and alternatives. And there is an alternative. Naturally, they can start off with a drop. I always pre-treat with an alpha-2 agonist, thiopidine, or alpha-GAN. And when we start off, I would advise to consider doing a 1-hour IOP check. even though the light study showed us that the risk of pressure spike is very minute, when you just get the hang of it, when you just start doing or performing the laser, I think it is prudent to try and see and check a 1-hour IOP. And the laser procedure is as follows. So when I start an SLT, I set the machine at 1 millijoules. And depending on whether I aim at treating 180 degrees in one sitting or 360 degrees in one sitting, I apply 50 spots or 100 respectively. I do advise as a first treatment or when you're just learning or getting the hang of how to perform safe selective laser trabeculoplasty, using or doing half of the trabecular meshwork gives you still an efficacious result with less risk of complications and an IOP spike. You can always repeat it twice or 3 times. Once you're more comfortable in performing the procedure and your patient selection is ideal, you can then move to applying 100 spots over 360 degrees for the entire angle. And your target tissue reaction is champagne bubbles, as we kind of see them over here, kind of laying on the iris, but of course, they originate from the trabecular meshwork itself. So post-laser, whether you consider in performing a 1-hour IOP check, that's totally up to you. I can tell you that I've been doing SLT for more than 10 years. In the past 2 years, I transitioned to doing subthreshold laser trabeculoplasty as well as SLT. And in my first subthreshold laser trabeculoplasty patients, I did want to see if there's any 1-hour IOP spikes. And we've checked all of our subthreshold laser trabeculoplasty patients for IOP checks. I think that's a safer approach in the learning curve. This way you can also notice who has a greater tendency to develop an IOP spike. Whether you're using non-steroidal anti-inflammatory in the initial 1 week after selective laser trabeculoplasty, that's up to you. There is a very mild inflammatory reaction that perhaps is what we need in order for the SLT to work. So perhaps giving a non-steroidal for a few days to prevent any unnecessary visits and to improve patient comfort is probably prudent. And my routine is to see the patient about 4 to 6 weeks after the laser procedure to see the effect of the laser. At the same time, I make a decision if there is a little or a lower response to the SLT. This is my decision. This will be my decision time to decide on an enhancement. So we saw from the laser trial that laser trabeculoplasty is superior to drops on compliance, better health economics, it is repeatable, and there's no patient factor to the treatment. I hope some of you, or not hope, but I'm probably, I'll be correct saying that some of us all suffer from dry eyes, and I'm sure we're not very adherent or compliant with our dry eye drops. And just imagine our patients having to put in a drop that stings or burns and maybe even blurs their vision. So the patient factor here is pretty major. We are still in the era of COVID, so least interaction with patient is probably the safest option because SLT doesn't require post-op drops or very short course of anti-inflammatory drops. There's no great concern of IOP spikes, and we saw from the LIGHT study, 1 out of 700 and some patients had an IOP spike. So most possibly patients don't need to stick around for an IOP check, and less overall office visits. So in conclusion for the literature, Selective laser trabeculoplasty and subthreshold laser trabeculoplasty offer a safer approach with lower IOP spikes. IOP lowering it is comparable to other laser trabeculoplasties. So we saw both SLT and subthreshold laser trabeculoplasty using anti-inflammatory drops in SLT and questionable if needed in subthreshold. In case of this LIGHTMED device, it's literally one machine fits all. We run, although I'm a glaucoma and advanced anterior segment practice, I do comprehensive ophthalmology. So if you need retinal laser for retinal tears or breaks or proliferative diabetic retinopathy, the nice thing about the subthreshold module is that you can do subthreshold macular treatments as well. And it really does offer YAG, SLT, subthreshold trabeculoplasty, argon laser for retina, but at the same time, the subthreshold focal or grid. Sorry for the spelling mistake there. So now I'll discuss a couple of case presentations. So I'll present two cases that are very typical in my tertiary care practice. So more advanced cases, and then we'll see a younger, very mild case. So the first case is an 87-year-old white female that has been followed in my practice and even in the by the ophthalmologist I took over for advanced open-angle glaucoma. She's got fields ranging until 1999, and I've actually looked at them, reviewed them again today. Best corrected visual acuity is good. She's had cataract surgery years ago. IOPs, at least in the right eye, are starting to trend up, and was 18 on a combination of a beta blocker and alpha-2 agonist. And we'll see her visual fields and nerve in a second. When I knew that we needed to escalate therapy, she wasn't keen on filtration surgery and said her vision is still good, so she doesn't want any intervention. And she's heard about this cold laser and saw a video with some champagne bubbles, and she was very keen to try that laser. So these are her fundus exams or fundus photos, and we can see very, very, very deep and large cup to disc ratio, a little bit of peripapillary atrophy from glaucoma, but also myopia, some small drusen in both eyes. Her OCT, we can see both RNFL is very, very thin and very advanced ganglion cell layer or ganglion cell complex loss. And when we look at her visual fields, and this is a progression analysis, we can see that her left eye potentially is maybe stable, but we can see definitely some progression in her right eye. So we decided to proceed with SLT for her right eye because of her advanced disease. I decided to kind of started a little bit on the lower end of the energy, so less than 1 millijoules, and I did do 360 degrees of SLT. However, I didn't do 100 applications. Again, I kind of erred on the side of caution and did only 80 spots. We did do a 1-hour IOP check because she has advanced disease and I did not want to miss any IOP spike. And we're about 12 months out now. Her IOP in her right eye is in her lower teens, which would have been my target IOP to begin with. And I think we're both pretty happy with the result. Second patient is another 74-year-old white female being followed for open-angle glaucoma. She had undergone phaco and angle surgery by myself, and post-op visual acuity best corrected was 20/20, and IOP was not on target. So right eye was 17, the left eye was 14, and she was on no drops. And we'll see her visual field, which was advanced on the right and moderate on the left. And we'll see that 17 is potentially not where we needed her to be. And again, this patient too was not keen on getting back on drops and wanted the laser procedure. So again, we can see both fundus photos, and we can see a very advanced cup to disc ratio, probably 0.95 in the right and a little less on the left. When we look at our visual field, kind of reminds us of the previous patient, so a very large superior arc rate, almost altitudinal defect, and inferior arc as well. So definitely advanced, fits what the nerve looks like. And if we look at the RNFL and ganglion cell layer, we can also see the nerve bundle defects on the right and definitely on the left as well. So with this patient, I actually decided to proceed with a subthreshold laser trabeculoplasty. Naturally, we treat with an alpha agonist. And for the subthreshold laser trabeculoplasty, the aim is to apply at least 120 applications, 360 degrees, to get the desired result. I did a 360-degree treatment of confluent spots. Spot size in comparison to SLT, which is 400, in the subthreshold laser is 300. The duration is 300 milliseconds, power is 1000 milliwatts, and because this is a subthreshold laser, the duty cycle was 15%. 1 hour IOP was safe, it did not rise. We're about 6 months out now. Her IOP is in the low teens, which is where we want with that type of or stage of visual field. And what was a little surprising for me, which was a happy surprise, that we are still able to do laser trabeculoplasty post angled MIGS. So the angled MIGS that she had didn't remove her entire trabecular meshwork. So there is an effect of the laser trabeculoplasty. So again, both she and myself were very pleased. Now, something that might be more typical for a comprehensive practice, a 36-year-old white male, which was referred to me by his sister-in-law, who's actually an optometrist in our province, had good visual acuity, but really elevated IOPs with suspicious cup to disc ratio and a strong family history of glaucoma. So best corrected visual acuity, 20/20. IOPs were 32 and 29 on no drops, thick-ish CCTs. His OCT, both ganglion cell layer and RNFL, are normal. The visual field and FDT are still show very poor reliability, and that's the reason I'm actually not showing them to you, because they're not really specific, and we're not textbook pretty. And the patient was not really keen on starting daily drops that might alter his appearance. So young patient, I always, when I start for example, a prostaglandin analog, I do mention the hypertrichosis, some adipose changes around in and around the orbit, and sometimes some conj hyperemia. So he was not really keen on any of what I had to offer. However, he was very keen on performing a laser trabeculoplasty. So again, here I actually chose subthreshold trabecular laser trabeculoplasty. Because his pressures were high already, we actually did consecutive eyes 1 week apart, just to make sure he doesn't spike. As usual, pre-treatment with an alpha agonist, we did get an IOP spike for 2 main reasons. One, I mentioned his pressure to begin with was already elevated, but also young patients tend to spike a little more than the more mature ones. So we did not get a spike here, and pressures are down to 22 in the right, 18 on the left. So all in all, a good result for now. And considering his age and family history, we kind of both know that this is likely not his last procedure. The nice thing about these laser trabeculoplasty procedures is that they are repeatable. That's it. Thank you very much for your attention. And this is my young son, and that's kind of, I guess, how homeschooling looks during lockdown, which we're in Miramichi, New Brunswick. So thank you very much.
Thank you so much, Dr. Shoham-Hazon. That was great, very informative, and thank you for going over all of that. Very interesting case presentations. So we do have a few part question here from our happy customer over in Nepal. So thank you for buying our laser. They're very happy with it. Something that they are actually new to adapting to their practice is the SPLT. They do have the Light Loss 532 argon laser like you have. And I did actually wanted to ask you to go back to case number 2 because he's asking about the protocol, what you recommend for your settings. I know you showed them on your case for the second one, but maybe you could just go over that again as a new user and about the patient groups, patient selection for that as well.
Can you see the presentation?
No, you just took your presentation off. Are you able to get it back on?
I have it back on. Let's see. Okay, there we go. Sorry. So, oops. There we go. So my parameters are kind of constant for now with the subthreshold trabeculoplasty because this is what is recommended at the moment in the literature. So I do try at least and get 120 applications. In this case, I always write if I get a little more, just for the sake of perhaps I'm going to get an IOP spike or something like that. Knock on wood, with subthreshold laser trabeculoplasty, I'm jinxing myself, but I have not had any IOP spikes. I do apply the laser throughout the entire trabecular meshwork, so the entire angle, so 360 degrees. The spot size is nice that it is a little smaller than SLT, because it allows you, if the angle is not really a Schaefer grade 3 or 4, so if it's not really as wide as you'd like it to be, you can still get in there. So you can still do the laser with 300 micron spot size. Duration, power, and duty cycle, again, it is what is currently recommended, and I have not yet played around or tried to tweak it. So I'm getting good results. So for now, I'm not, I don't feel like I want to tweak it. Albeit I am doing patients that are maybe more typical for a tertiary care center. So I'm seeing maybe the more advanced glaucomas, patients that are already on therapy, and I'm still happy with the results. But definitely, I think more research should be done on the comparison. And we wanted to talk about patient selection. Was that the second part?
Yes, he asked if it's applicable for all patient groups. Yes.
As in which type of patient groups? So so again, I can say that open angle glaucoma, I think uveitic glaucomas are definitely have place with subthreshold laser trabeculoplasty, as well as I think some SLT options, but definitely with subthreshold laser trabeculoplasty, uveitic should be considered, because there's very little tissue interaction with the subthreshold laser, so there's barely any inflammation. Frankly, for SLT, I do give non-steroidal anti-inflammatory drops for about 4 days. For subthreshold laser trabeculoplasty, I don't give any post-laser anti-inflammation, and I haven't had, for now, again, I don't want to jinx myself, but I haven't been burned. So I haven't had any patient calling or coming back and saying, I had like a big headache for 4 days. So I think that's for the post-op care. And I think with SLT done safely and subthreshold laser trabeculoplasty done safely, I think any stage of glaucoma is worthy to be treated with it, especially if you think you'll reach your target IOP, and especially if the patient is not keen on having something more done or more invasive if you think it is necessary. So I think it's definitely worth attempting.
Okay, perfect. And with your experience, you're using a 532. I know LIGHTMED does
Mhm.
offer a 577 as well. And the case you presented earlier is using a 577. And I can't remember, was that protocol the same, or was the energy delivered a little bit differently than the 532?
So I think, and I've looked into the various energies, and the energy is the same. I looked into all the data of the different subthreshold laser trabeculoplasty and MLTs as well. And if I'm not mistaken, the values are the same.
Okay, perfect. And just for everybody who doesn't have a LightMed, we do offer the 532 and 577. But just as Dr. Shoham-Hazon has said, he's using a 532, and that is his recommended settings, and with no IOP spikes so far. So that's great to hear. And just as follow-up, the same person is asking so for post-op, using SLT, you recommend the NCOD, but while SPLT, you do not. Is that correct?
That's right. For SLT, because you do see some little bit of inflammation with SLT on occasion, my routine was to give and is to give non-steroidal anti-inflammatory. It can be, any of the brand or generics that are available and are not so expensive because the inflammation is so mild. Um, but for the subthreshold laser trabeculoplasty, I don't give any anti-inflammatories.
Perfect. And you did mention that these are repeatable procedures. How often can you repeat it, or have you seen it done?
Very good question. So something that actually came out of the light trial, and reading it and also listening to the writers of the paper, you can repeat it 3 times. Some even repeat it more than that. And from the light trial, something that was very interesting that came out of it is that even performing an SLT for the third time was as efficacious as the first time. So that's a little bit of a game changer because we knew and we thought in the past that with each laser treatment, the efficacy decreases and the time that the laser works or the effect of the laser wanes. But the light study actually showed us that the third attempt or the third laser treatment can be as good as the first. And for the subthreshold laser trabeculoplasty as well, I would tend to repeat it twice. If I get a good response, I'll even consider a third time.
Okay. That's good. So I've actually had this come up. This is a question from myself. You do have a great picture of like the champagne bubbles that we see on the trabecular
Yes.
meshwork. And that's how we know that it works. And a lot of times I know that the protocol is, to treat here, and as you had put, like about 1 millijoule. So what kind of advice would you give somebody who doesn't exactly see the champagne bubble? And I mean, they get a little bit nervous when they're increasing the energy and they don't want to apply too much. So does it happen all the time, or how do we know if it's working?
That's a very good question. So some people start with zero point 0.6 millijoules. So um, the laser that we have, we've got 2 different lasers. So in my practice, we have the LIGHTMED. At the hospital, we have a different one. Starting with 1 millijoules can actually is a good place to start, because if you see too many champagne bubbles, you kind of titrate down the energy. I wouldn't go as much as we have written here, 0.4 or 0.6. I would want to see some champagne bubbles with every application. I don't want to see as many as actually the image shows, because that's a lot. Something that is very nice with SLT is when you apply the laser, you can see very mild target tissue reaction or interaction. You kind of see the tissue move a little bit, and with that, you see the champagne bubbles. If you don't see any, you can go as much as 1.2 millijoules just to get some tissue interaction. But again, you have to be very familiar with the procedure. And that's why I wrote 1 millijoule, because that's the safest place. If you get no champagne bubbles, I would probably go to 1.1 or 1.2 millijoules. And then when you get the champagne bubbles, again, titrate down.
Okay. Is it different for light pigmentation or darker pigmentation, have you noticed?
For sure. So with lighter pigmentation, you'll get less of a tissue interaction. So you might get less of champagne bubbles. And with lighter pigmentation, you might even get less of a reaction altogether with the laser. With heavier pigmented angles, you need lesser energy. And those are the patients you have to be a little concerned about an IOP spike. So if I see someone that has +3, +4 pigment in trabecular meshwork, I first of all start with very low energy. And those are the patients I definitely get a 1 hour IOP pressure on.
Okay, and you said 180 to 360. I mean, how do you determine if you do half or the full eye at that time?
Good question. So I consider the risk of IOP spikes. Again, I have maybe a practice that's a little skewed toward the higher risk patients. So if I am concerned of a patient spiking, a more advanced field loss, younger patient, has more pigment in trabecular meshwork, starting off with a high pressure, those are the patients I would kind of go low and slow with. So those are the patients I would start with only 180 degrees and about 50 spots, and maybe even titrate down the energy. So maybe not even go 1 millijoule, maybe go a little lower, because all those 4 factors are pretty risky for encountering an IOP spike. If you have a patient that is maybe an ocular hypertension, maybe not starting with an IOP of 32 like I showed, and you're not concerned of an IOP spike, there is a lot of reserve in the nerve still looks good, then you can go 360 degrees and treat with 100 spots.
Okay, very good. And do you have any recommendation on like the type of contact lens that you use?
So we have 2 types. Of course, we've got the Latina SLT lens. We recently purchased a gonio SLT lens that is called Rapid SLT. And that lens is technically, it has 4 gonio mirrors, and you have the ability of not rotating the lens. Because they're 4 gonio lenses, it covers the entire 360 degrees, and you can just move on from one mirror to another, so you don't have to rotate the lens. But any lens that has the gonio part, that has the special coating for laser, that won't pit the mirror, you're good with. It's basically your comfort, whatever you're comfortable with.
I've actually heard about the Rapid one. Do you like it yourself?
Um, I'm still rotating it. So you're not supposed to rotate because it has
Mhm.
4 mirrors. I'm
Mhm.
so used to rotating, and I always feel like there's a little gap between one mirror and to the other. So
Mhm.
so I kind of still rotate it. I know it's weird. I got the rapid SLT and I rotate, but that's it's just a force of habit. That's what I've been doing for 12 years, so that's what I do.
That makes sense.
Yeah,
Okay, well, we just have a couple minutes left, time
sure.
for, I guess, the best question. A couple questions here, but what features do you consider when buying a laser, and can you comment a little bit more about the optics? I know that's something that you said is superior, but what do you love about it and the LIGHTMED system?
Right. So I'll put on, let's see. I'll put on, yeah, mine. So that so something that was very important for our practice was for the machine to be mobile. So for it to be able to move. I don't love mobilizing instruments. So it was just it stays within one room, but we kind of rotated 90 degrees to be able to be operational and comfortable. So the table has to be comfortable. I'm kind of starting back from maybe the least important to the most important. The most important for us was that it has a capability of doing all in one. So I wanted a device that naturally is a glaucoma subspecialist. I wanted to have SLT. I wanted to be able to have a YAG option to do LPIs. Um, I want, again, the newer technology out there is the subthreshold laser. So I wanted to be able to have the subthreshold option for trabeculoplasty, but I also wanted a retinal laser that I was comfortable with, which is what I've always worked with, which is the green 532. And I wanted to have the opportunity with a green laser or with a subthreshold retinal laser to be able to do macular laser, focal or grid with a subthreshold setting in a safer option. So having all in one, and to be honest, the machine works amazingly well. When you see me here, so our senior ophthalmologist is actually doing my retinal laser, and when he put his eyes, and these are eyes that have seen lasers for 25 years, the first thing that came out of his mouth was, "Wow, the optics are superb." And it is true. So sometimes when you do retinal laser, for example, you kind of have to have a memory or a picture of where the tear or where the pathology is in the retina from your lane, and then implement it on the laser because the visibility is not, or the optics are not that good with retinal lasers. With this LIGHTMED laser, the optics are so amazing that you don't need any imagination. So when you see the pathology in your lane, you're 100% going to see it in this machine. So the optics was very, very important for me. So it's kind of like an all-in-one. It works well. It's easy to mobilize. You can do any laser treatment that you want with this. I didn't mention laser suture lysis for trabeculectomies because I've transitioned to rarely doing trabeculectomies anymore. I do MIGs and tubes. So, but naturally, if you do perform trabeculectomies and you need to do laser suture lysis, that's where you need the argon for. That's 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 why I like it.
That's perfect. I mean, fortunately for you, you get to be the patient and the doctor, so you've been on both sides of the machine.
Exactly. And you know what? On the patient side, it was super comfortable. So these pictures are actually in our old center. So I'm actually sitting in the slit lamp chair, so in the unit chair. So the table goes up so far up and so far down, which makes it so nice for the patient. So it is really, really comfortable. We always have those really big, tall patients or guys and those small kyphoscoliotic um, ladies or frail elderlies, and the machine just goes up and down. The table goes up and down as much as you want. So it is really very dynamic for a dynamic practice.
Very good. Well, that's the hour. That will leave it on that really good note there. And I see a lot of compliments already coming in. So excellent presentation tonight. We really appreciate your time, and we look forward to
Thank you.
seeing you again very soon.
Thank you very much. And if someone has questions, they can either um, email you and you can forward it to me, or give out my email. I'll be very happy to share my experience.
Thank you so much. We really appreciate that.
Thank you.
All right. Have a good evening.
Thank you.
Bye.